We will get started. My name is Kishore Iyer. I'm a intestinal rehab and transplant surgeon in Mount Sinai. I looked at Dave Mercer and I almost said Omaha, ex-Omaha, with still fond memories of Omaha. To sort of complete the story, Swapna Kakani will follow me. Swapna hopefully needs no introduction. She's, I repeatedly say, a force of nature, herself the right term is consumer, but also very interested in the issue of access to care for intestinal failure patients, and in fact, more importantly, the difficulties in access to care. Will follow with Kelly Tappenden, who's now the Dean at Utah Health, who knows this business very well with her comments. Marion Winkler, friend, colleague, quality of life expert, will speak about quality of life issues and how we're going to integrate that in. And with that, I'm actually going to, what we wanted to do today was to pitch a research proposal to the consumers. And in fact, you are the first group of patients, patient advocates, stakeholders who are really formally hearing of this research proposal outside of us. I will say that the proposal we're going to talk to you about is a pilot project, proof of concept, that is funded by the NIH through the Agency for Health-Related Quality. It's a limited project of an idea that we're very excited about. But to set the stage for it, I'm going to ask Swapna to come and give a few comments to describe her own journey that reflects the difficulties many patients experience going through intestinal failure. Swapna.
Good morning, and thank you everyone for being here today. It's an early Saturday morning, and it's really nice to see everyone's faces and to see familiar faces in this room, and thank you for listening to us. So my name is Swapna Kakani, and I have a public health background, and I'm a consultant and researcher on the Lift Echo, Dr. Iyer's research team, which we'll talk about. So first I want to share that the person you see today, the voice you're hearing from me, the confidence, is not who I was 10, 15 years ago. And that is because in the last 10 to 15 years, I have found out the really hard way, after hitting rock bottom after rock bottom, of the importance of putting the patient at the center of the healthcare team and taking ownership of my care, and really creating my own pit crew of a multidisciplinary team that has influenced my outcomes today. So 10, 15 years ago, I was stuck in a local hospital where I was born and raised in Alabama. I'm a child of second generation Indian immigrants and child of Indian immigrants. And we were lost. I was born with short bowel syndrome in the late 80s. And I have lived on TPN and or tube feeding and an ostomy for most, if not my entire life. I continue to receive tube feeding even today. And I had repeat surgical complications and surgeries to maximize the gut I was born with. That's what we all aim to do, to hopefully wait for that science that is coming. And I was born in an era where we did not have, I'm looking at the companies behind us, and some of them weren't even invented in the late 80s. And so we were stuck in our local hospital where I had surgery that just resulted in complications after complications. And we came to this conclusion that we have to get out of here. We took our care in our own hands as a patient and as a family. And what many in the rare disease field and what many in this space do is we traveled all over the country for second opinions for that subspecialist, where we learned that we did need to have surgical resection, and then I made the difficult decision to have a small intestine organ transplant now 10 and a half years ago. It was through that journey that I learned, and the right care at the right place at the right time is imperative. And so I had transplant at what we call one of the best hospitals in the world. And I was 24 years old, and it was because of where I was and my age, this graduation into adulthood, where I learned that I have to take control of my health. And it was conferences like this, coming to Oley, really late in life, but coming to Oley, seeing who's speaking, seeing the experts in the space. I have created my own pit crew of a multidisciplinary team in across 4 different states. In 35 years, I've had 68 surgeries, 31 central lines, 26 central line infections. And I said, this is the end of that. We have across 8 hospitals in 7 different states. And I said, no. So I will choose the full-time job of coordinating my care. And a lot of times we become the victim. We become stuck in that coordination, that communication between providers. But it is imperative that we own our own care. And I coordinate this care between the pit crew because I swear by it is the reason I'm standing in front of you, being able to talk about this with health and life. But no one else should have to do that. No one else should live through what I lived through, and no one else should have to move for the care they need. We're in year 2025, and it's really not right care at the right place at the right time. It's right person at the right place at the right time. Thank you.
So you know I wasn't kidding when I called Swapna a force of nature. We've been, I want to say, friends, and now for quite a few years. By the way, just in case you're thinking, what was wrong with that transplant? I didn't do her transplant. But her story is very real. And she is correct in saying that she had her transplanted at one of the premier centers in the world. But Swapna's problem of having to find her own pit crew and to effectively cobble together an expert team, if necessary, moving through different states, different teams, different doctors, is not easy to accomplish, is not within everybody's means, either by virtue of ability to advocate for oneself, financial, geography, even awareness. And this has become a huge problem to solve. For those of you who are not familiar with intestinal failure, when your intestine doesn't function enough to meet its body's needs by eating and drinking, and you need some IV nutrition or IV fluids, TPN, most of you may be aware, then you have intestinal failure. Now, there is a huge amount of data that says patients with intestinal failure do best when they're managed by expert multidisciplinary teams. There's a mouthful, all of that matters. Expert matters, multidisciplinary matters, teams matter. David Mercer and I are both surgeons. We often claim we know just about everything, but we know that that's not true. And we need gastroenterologists, hepatologists, expert dietitians, nurses, social workers, financial counselors, pharmacists, radiologists, you name it. And I remember in 2000 when I was in Omaha and we hosted the International Small Bowel Transplant meeting, somebody said, I didn't know small bowel transplant was such a big thing. There are so many people here. And the answer really was, it was not that it's a big thing. It takes a lot of people to look after the small number of patients. And intestinal failure is a rare disease, estimated 30,000 patients in the US. In case the people who decide and control the purse strings think, oh, we shouldn't give it enough attention, it's also an expensive disease. Uncomplicated TPN for a year costs about $100,000, give or take. There's a new drug, relatively new drug, now in its second decade, teduglutide. estimated cost about $300,000 a year. If things go bad, TPN complications, costs can rise to about $500,000 a year. Intestine transplant can cost $1 million. So apart from the very real human burden that you, your friends, your families, and perhaps consumers you're aware of outside this room go through, there is also a financial burden. So David and I are privileged to work in large centers that have the expert multidisciplinary teams, but there are only a few of us. At last count, across the 50 states, there were 26 adult intestinal rehabilitation programs. So if you're in Montana, North and South Dakota, Arkansas, good luck if you're an adult with intestinal failure. Swapna's story is not atypical. Alabama, and she had to travel across the country. She's racked up the miles, certainly. So we've been thinking about this issue for some years now, and looking at how best do we solve it. Look, telemedicine helped a little bit, but each state functions as its own republic. I don't want to get into politics. That would not be good for my blood pressure. But the fact of the matter is there are so many rules governing telemedicine. I can't see a new patient. I can't see a patient from a state where I don't have a license. That really doesn't help. And it's really, as I said, impractical for patients to travel long distances, even though for those who have the wherewithal, that's the option. A few years ago, I came across the work of a guy called Sanjeev Arora, who's a doctor in New Mexico, and he was dealing with a very similar problem, but in hepatitis C. A bad liver disease that, if not managed, leads to liver failure, transplant, etc. And he came to a situation where in New Mexico, the second poorest state in the country, he was the only liver specialist. And there was an epidemic of hepatitis C. He did what he could, but the wait list to see him, waiting time became 10 months very quickly. And he realized that that was not feasible. And he tells the story really quite dramatically of a middle-aged woman who came with a grown-up son, and she traveled many miles. She'd really come off the reservation. They traveled about 6 hours to see him. She had treatable hepatitis C, but then disappeared from follow-up. And when he saw her about 8 months later, unfortunately, by then she developed a liver cancer and couldn't be saved. And in its distressing conversation with her and the family, when he asked, why didn't you come sooner? I could have treated you. They said, well, you're 5 hours away. It's a long time to wait. I just couldn't do this. And he then started telemedicine way ahead of his time, about 20 years ago, but realized very quickly telemedicine doesn't solve it because there's still only one of him treating one patient at a time. And he realized very quickly that the answer to his problem for hepatitis C was not for him to do it, but for him to train other non-specialist liver doctors to manage their own patients where they live. And that started the ECHO project, Expanding Community Healthcare Outcomes. He published his results in the New England Journal of Medicine. If you don't know, that is the premier journal. That's for academic physicians. That's like getting a small jackpot, and that he did that. And really today, there are about 290 papers written about different ECHO projects. You name the disease, there's an ECHO project. Hepatitis C, HIV, hepatitis B, chronic pain. And in over 60, 80 countries, I think, there are ECHO projects going on. At last count, he and I talked a month ago, there were 1,009 different ECHO projects around the world. So about 5 years ago, I had an aha moment when I stumbled upon his work, of all things, on social media. I don't do social media much, and I reached out to him and I said, I think this is what I need to do for intestinal failure. And that was the beginning of the LIFT ECHO project, Learn Intestinal Failure Tele-ECHO. Everything I said to you about hepatitis C, just substitute intestinal failure. And because I knew I may not be very smart, but I have a lot of smart friends. I call my good friends, Kelly and Marion, a few people from Oley, a couple other people, and we took a team out. We took a big bus to New Mexico. I'm kidding. We went to New Mexico. We learned how to run the Echo project, and that's how we launched the Lift Echo project in 2019. And the way this works is very simple. It's really like in academic hospitals, there are what are called professorial grand rounds. Somebody presents a case without any identifying details, and then the expert professor facilitates discussion and provides some recommendations and then gives a lecture. So an echo clinic is modeled on those professorial grand rounds. So we have the way we run the Lift Echo clinic. We started with 2 adult clinics. We added a pediatric clinic once a month. So 1 hour at a time. After a few minutes of introduction, somebody presents a case that is anonymized. We have a very simple template, and they present what they're struggling with, and I facilitate discussion. If they need it, we provide recommendations. And in about 30 minutes, the case discussion is done, and then we have an expert from somewhere in the world who presents on a topic that's relevant to intestinal failure. That was the Lift Echo project. And to give you a quick idea, we've done now over 75 adult clinics like that around the world. I say around the world. All coming out of our little, it's like a Zoom clinic. Most of you are Zoom experts, I suspect. But believe it or not, we have participation now from 6 of 7 continents. Of course, my wife said to me, how come there's no intestinal failure in Antarctica? But still, you can understand the need there is. We have participation from 42 states, doctors signing in. I say doctors, it's dietitians, it's pharmacists. And the beauty of it is that the participation is as multidisciplinary as we want it to be. We've added a pediatric clinic. We've done about 50 pediatric clinics. But there is a problem with Lift Echo. Lift Echo requires that now I'm going to take 2 mythical characters. Dr. John Smith in Montana looking after Ms. Jane Doe. So unfortunately, I have no means of knowing who and where is Dr. John Smith. I have no means of tracking down Jane Doe. And so Dr. John Smith may have only 1 patient with intestinal failure. He's not an expert. He's not claiming to be an expert. By the way, this is gender neutral. You can make up your own names and genders. But Dr. John Smith desperately needs help. He's never heard of Lift Echo. He's never heard of Kishore. He's probably a little happier because he's not heard of me. But he is struggling. And Ms. Doe is struggling, keeps going to the hospital, infection, line gets pulled, whatever. You can imagine the scenario. These 2 people need our help. They don't know how to get it. Dr. Smith says, oh, I can't manage you. You have to go to Omaha and get care. And she says, are you out of your mind? I'm not going all the way to Omaha. So you get the problem. So how do I find Dr. John Smith? We're trying. That's the current Lift Echo project. And when I talked about this in previous Oley meetings, I had patients come to me and say, well, that's for doctors. How? I don't know if my doctor wants to participate. What's in it for me? So that's what we're here to tell you. We have an idea that's all about you, the consumer, you, the patient. So it occurred to us that really the struggle we're having trying to get the non-expert Dr. John Smith into our project to say, we want to educate you, Dr. Smith. Will you devote 8 hours, 12 hours, let's say over 3 months, come to our clinics. You won't become an expert, but you'll know enough to manage Jane Doe safely. A, I don't know who Dr. John Smith is. I don't know how to get hold of him. B, maybe Dr. Smith's in a very busy primary care practice, and he says, I don't have the time for this. So it suddenly occurred to us, if we could target Jane Doe directly, if we could find Jane Doe and explain to her how does echo work, we're going to try very hard to give you, Jane Doe, a level of expertise that helps you advocate for your own care, understand at least the high principles If you have a fever and you go to the ER, don't immediately let them pull your central line without thinking about it. That type of basic principles in intestinal failure care that we take for granted, if we could somehow convey them to Jane Doe, then we would perhaps start beginning to crack this problem. And that's the proposal we submitted to the NIH. They love the idea. If we succeed, it'll be the very, very first out of, like I said, over 1,000 echo projects that is directly targeting the patient, that claims, that wants to make the patient an expert in their own care, that wants to help them advocate for their own care, and hopefully improve their outcomes. And if your mind is racing ahead of me, I'm with you. If you think, wow, could it be, think ahead, could it be that a patient who's really motivated for his or her own care learns more and more? There's no limit. Learning, there's no premium on learning. It's all constrained by you. So if the patient says, what if I learn enough that now Jane Doe goes back to Dr. John Smith, who's too busy and not interested, and says, Dr. Smith, let me tell you how it's done. We want to turn the echo model on its head. That's the project we're proposing. This is a purely pilot proof of concept project. The NIH loved the idea. They've given us funding for a year. We're just sort of gearing up to start patient recruitment. And we really, part of the reason we want to do this study, how best do we do it? What do patients really want? What will matter? What will be effective? What will be useful? That's what the study is going to be about. Today, we don't want anything from you. We want you to think about it, spread the word, tell your friends, tell your aunt. Is Jane Doe in the room? Kidding. If you know Jane Doe, tell her. And we are coming for you. That sounds like a threat. That sounds like Uncle Sam, I'm coming for you. No, we are interested. Okay, with that, I'm going to actually stop and ask Kelly perhaps to make some comments, and then Marion about the thoughts, because I can ramble. I may have missed something. Thanks, Kelly.
Thank you, Kishore. Always entertaining, right? Hey, so I want to build on Swapna and Kishore's comments and really tell you just about a little journey that I've taken in the last 2 years that has changed my perspective on all of this. I have been so honored to be involved with Oley and all of you over a number of years. I'm missing you since I stepped down as president last year. But just before I did that, I moved to Salt Lake City. So I had been in Chicago and Illinois for nearly 30 years and committed to consumers with receiving specialized nutrition support and intestinal failure, which I know not all of you are, but certainly the specialized nutrition support, whether it be enteral or parenteral nutrition. From my perspective, being in Chicago, I was center of excellence all the way. I wanted each of you to get to a center of excellence. And the fact that we were losing patients because they couldn't get to a center of excellence was, I was distraught over that. I really wanted everybody to get that excellent care. And I still do. I absolutely do. But in moving from Chicago, where we have University of Illinois, we have Northwestern, we have University of Chicago, and all of these excellent providers, I went to Salt Lake City, where we have an amazing healthcare system, actually very, very highly ranked. Not necessarily an expert, though, for all of you. And that is a real problem in the Mountain West, actually. When we look at those states, there's a void of centers of excellence for all of you. And though I'm at one of, the highly ranked healthcare systems in the world, in the country, when I look at the Salt Lake Valley, it's very interesting and has really taught me to ponder this whole very issue. How many of you have been to Salt Lake City? Okay, so I see several hands. So you know the beautiful valley that we have, which has the Wasatch Mountains on one place, the Ochre Mountains on the other side, on the west side of the valley. The healthcare system, the University of Utah, is up like this castle on the hill. And I'm fortunate enough to have a glass-lined office that looks out over that valley. So I see the Wasatch, I see the Ochres, I see the lake, and I see the beautiful valley of city in between. Now, the interesting thing about that is if you compare the residents on the east side of the valley where my office is and the university is versus the west side of the valley, which I can see, it's only like 5-7 miles away just along the Ochre Mountains, the average length of life is 10 years different. 10 full years difference in life expectancy. That exists in Chicago too, but it was not so beautifully laid out for me like it is from where I perch on the Wasatch Hills. That's a huge disparity, and it's really got me thinking about social determinants of health and these terrible things that where people in the West Valley don't get up to the castle on the hill to get their health care, and that has a huge impact on their lifespan. If we're talking about that in a general population like this, imagine that among the members of Oley, right? And so we're dealing with people who need that health care so very badly. And I think that those of you who are here, you've come to this meeting, and so you're going to go find the very best healthcare that you can. And if you're in Utah, let me help you out with that, okay? You're going to get to those centers of excellence. But imagine all of those people who are living in these areas that aren't able to access that. For us to say, well, go to Nebraska, go to New York, all of these things is irrelevant to them because they aren't even making it across the valley, right? And so what we really need are programs like this where Lift Echo is going to come to them and we're going to be able to provide them with that healthcare. It really resonates what Swapna says about it being centered around that person, around that patient. Even in a population like our members in Oley, get to centers of excellence if you can, but we're not looking at the whole situation very clearly if that's the only solution that we're providing to you. We also need to be thinking about patient-centered care, and that's what this opportunity is. That's what this advancement is, to be able to give the patients the access that they need and to center that care around them wherever they are. So please, talk to Jane Doe, get involved, and I will turn it over now to Marion.
Thank you. I am going to speak briefly about patient-reported outcomes and quality of life. Excuse me. Patient-reported outcomes are really what matters most to the patient, to the consumer, to the family. And when we think in the healthcare field about outcomes, we tend to think about length of stay in the hospital, reduced complications, things like that. But we know that individuals have very specific outcomes that matter most to them. So in this patient-facing echo, we are going to include some patient-reported outcome questionnaires or interviews. And the tool that we're going to use has been based on extensive interviews with consumers like you. Over the last decade, I've spent a significant part of my research time interviewing individuals about their own personal definition of quality of life. What does it mean to them? Using that definition, how would they define and evaluate their own quality of life, and trying to engage our patients and our families into more of a discussion about quality of life rather than a number on a questionnaire. And so through that work, it was very clear that the definition that resonated, that it really percolated it out of every individual. I didn't make it up, but there was a theme in the interviews about being able to do what I want to do when I want to do it. And the things people want to do is participate in activities of life. You know, travel, go on vacation, eat and dine in restaurants, attend church and social functions, do housework. I don't want to do that, but others do. Take care of family, you know, the things that we do every day. And I think that those are really important for us to be sure that the care we provide and the treatment we offer absolutely impacts being able to do what I want to do. So some of the other features in the intestinal failure home TPN dependent population was I want to be able to sleep through the night without waking up and peeing every 5 minutes. I want to be able to leave my house without having to worry about where the bathroom is and, you know, having too much diarrhea and high output ostomy. I want to be able to emotionally cope with what I'm dealing with, whatever it is. I want to feel trained and educated and confident in being able to do my own self-care, recognizing signs and symptoms of dehydration, central line infection, the diet and what should be included or not, things like that. And so the patient-reported outcomes that we'll measure at baseline of attending this echo clinic and at the end, we'll have those patient-reported outcomes embedded in the questionnaire or the interview, whichever way we do it. And we're pretty confident that our education program will impact quality of life and education because, as Dr. Iyer said, you know, knowledge is really power, and we, as Swapna said, we want to maximize patient voice. So I think having this education will be able to demonstrate these outcomes. And then in other work we're doing, we want to provide education to physicians and other healthcare practitioners and demonstrate that teaching them improves patient outcomes too. Thank you.
Thanks, Marion, Kelly, and Swapna. The pitch is done. Do you want a used car? No. But we're ready for questions. I don't know if we have a second mic, but we'll keep it casual. We'll figure out who's the best person to answer. You had a question.
So, a lot of people are very good. A lot of patients are already very knowledgeable about how to manage their own care. The problem is, how are you going to educate that patient on how to educate their clinician? Because that's where probably the biggest problem is. And then you're still doctor shopping to find somebody who's actually will listen to you.
That's an excellent and important question. It's a fair question. But I'll tell you, despite what I just said, I don't fully agree with you. Everybody is not an expert in their own care. Kelly mentioned it. The fact that you're here, you have already selected yourself at a higher level of expertise than, unfortunately, many patients who don't know about me, don't know about Omaha, don't know about Oley. So the people, in fact, in some ways, we're already pitching in the wrong place. The patients who come to Oley Foundation, who are aware, are really not the patients even don't get me wrong, everybody can benefit from some help to improve care, but it's the patients who don't even know that there's a higher level of care. You at least know what you don't know. You know what your doctor doesn't know. What if you don't know what you don't know and your doctor also doesn't know what he doesn't know? You can compound this many times over, right? And so that's, in a way, that's a challenge to us also. How do we get to Jane Doe of, did I say Montana? Montana. Sometimes it's Arkansas, but this time I think it was Montana. But I'm being a little facetious. But there are patients with intestinal failure who are literally behaving like children of a lesser God. They don't know what they have. They don't know what they're suffering. Their doctor doesn't know or doesn't care. In a way, that's a challenge to us. And we're actually going to try and study very hard the very question you've asked. We're, like Marion said, we're very confident that if we bring patients like, I don't know if you're a patient, but if we bring patients like the patients who come to Oley, but I didn't want to presume. If I couldn't see the tubing, you could be just carrying the tubing for her. I'm kidding. I really am kidding before I dig my hole deeper. But you know, the issue you asked is an interesting one, and unfortunately in healthcare you don't want to be interesting. You really don't want to be having to face the challenge, what if I tell my Dr. Smith you're doing it wrong, and not only does he not agree, suppose he turns around and says, you've been difficult all my life, go find another doctor. So we're cognizant that despite good intentions, there is potential for harm, and we want to study that very carefully. That's why the proof of concept study. There are many unanswered questions. We think the idea that you educate especially interested patients and family members on the principles of care for themselves, on what's important, how to advocate, some knowledge sheets, simple. We're confident that that might improve their own care. How will their relationship with their doctor change? We don't know, but it's an interesting, important question. Yeah.
Sure. I think it's worth talking. It's worth mentioning that we also have a parallel study looking at the providers and whether or not this model can actually increase their knowledge. Now, it doesn't address what it is you're saying, because some of them aren't going to participate, right? And then you're left shopping for someone who's saying, okay, perhaps I don't have that knowledge, and maybe this is a way for me to get it. So it doesn't answer the core of what the doctor shopping, but we are trying to look at this model from the provider side of things and see whether or not we can improve their knowledge and the care that they're providing also. Yeah, of course.
I think it's very important, and we will address communication skills, because, you know, obviously we're not going to encourage people to go in with, you know, and say, here's how you should do it. I think there's an approach that might work, and it could be something to the extent of, like, you know, I'm participating in this education program, or I come to this Oley patient advocacy organization and I'm learning that there are a lot of experts in the country and in the world. There are very few, but there's a core group of them that exists that can really do. I'd really like to have a referral, or I'd really like you to pick up the phone and call. I work in a non-intestinal rehabilitation program, but we have expertise in the management of home TPN and short bowel syndrome in Rhode Island, in the Mecca between Yale and Boston. And, you know, we're a small, Rhode Islanders don't leave Rhode Island, never mind go across a valley. But I can't tell you, 4, 6, 8 times a year, we do a telephone conversation about the patient with Dr. Iyer or with Dr. Mercer, or I do it peer-to-peer with Carol, who's an expert GI dietitian, and get information that can then be used on behalf of my patients. So there are a lot of mechanisms and strategies that maybe we can teach that aren't used, besides just, you know, this is what I learned and this is what I think you should do on my behalf. So the art of communication will be important.
So I'll just add, I want to also say thank you so much for the question, because that has been brought up in our research approach to this. That was the #1 question when we brought this to organization leaders as well as fellow parent advocates and patients, because we know that it doesn't always, it's not roses and rainbows. And so #1 is also, so we'll have disclaimers and the appropriate language, but also to understand I think the approaches that have worked and show, but that there could be consequences. And I think that's a truth that we all have to know in advocacy and in speaking up and being comfortable with the consequences and having second plans, or I've come to a point where I don't know if I have anything else to lose, but that's not everybody's feelings or motto. It's a double-edged sword. So I want to say that. And then in our recruitment, when Dr. Iyer's talking about Jane Doe from Montana and to separate those that are, I mean, to come to a conference, it is the cream of a crop of any conference you go to in any setting. There is privilege to attend. So we have a specific diversity recruitment method there where we're very keen on the person that, like I was before this whole journey of a minority from a state or geographic area that has no, or a very long distance from an intestinal rehab center and the definition of intestinal rehab center. So we are being very cognizant of all this. So I really appreciate you asking, Crystal.
I have one comment before I go to Michael, who has a question, which is, that's actually a thorny question for us also, and the agency also recognized that that's a thorny question that needs to be addressed. Just because it's thorny and uncomfortable doesn't mean we shouldn't try to address it. And with some of it, it's amazing what pressure and embarrassment can do for you. I wrote a paper about 2-3 years ago showing that the vast majority of gastroenterologists in the US don't know anything about intestinal failure. You can imagine I'm not getting too many Christmas cards. But it's amazing the impact that little paper has had on the GI Society's behaviors. So I think we should keep pushing. The current status quo for intestinal failure patients is clearly not acceptable. Michael? Good to see you, by the way, Michael.
Good to see you all too. So what is the best way to do this? Are you saying there should be maybe a special Oley ambassador network made up of people like Swapna and Vince and people like that from the Oley community? Like, or should we go right into the hospitals, like to get to doctors to get to patients? Like, we're already direct through Oley, but that's not enough, right? So
I've just been shown 0 minutes and a cane, so I'll keep this very short. We're still mulling some ideas. Swapna is helping coordinate with some Facebook groups. To some extent, no offense to the people here, to some extent, we're not looking for the expert patients. We're really looking for Jane Doe. She's a needle in a haystack, and our problem is we don't even know where the haystack is. Never mind the needle. I'm exaggerating. But we have some plans. I think your idea is a good one. We'll watch the space is all I'll say, and with that I'll stop. Find us, Swapna, everybody knows. I think there are not too many silver ponytails around. So if you have an idea, you have a question, grab us.